It just takes me a minute to switch from one presentation to the next. So if there's a little bit of a delay, but we verify that they're all here, so we're good to go. Yeah, right. Well, yeah, exactly.
I'm Sharon. How are you? Nice to meet you, Grace. Why don't everybody come up? Jenny, why don't you come up? We'll just have everybody sit up. Yeah, and then, I'll see if you're in. Yeah, they're all gonna. Oh, I see. Yeah. Our time. We're going to sit on that. Yes.
No, I was right.
Got it. Oh, yeah, why don't you-
Yes.
Ouch. Okay, yes.
All right, we'll go ahead and get started. Good afternoon, everybody. Welcome to Understanding Mesh Options. We have almost all of our speakers here. We're just waiting on Dr. Tofai, but I'm sure she'll come and join us since her talk is a little bit later. My name is Fareed Chima. I'm an assistant professor at NYU Langone.
And I'm Sharon Bachman. I'm an associate professor at UVA, and I'm at Inova Health System. And hopefully we have a lot of mesh geeks here. And I'm going to start out by introducing one of my old friends and favorite mesh geeks from Oregon Health and Science, Dr. Sean Ornstein, who's going to do our first talk on permanent materials.
All right. Well, thank you for that introduction, and good afternoon to everybody. Topic near and dear to my heart. Again, fellow mesh geek with all our other brethren up here. Here's my disclosure slide. You can see my disclosures. Shockingly, I will be discussing mesh in my lecture today. So I've tried to remove as many name brands as I can, but I will be discussing various mesh prosthetics throughout my talk. A lot of stuff to go through. I'm going to start talking about some of the constructs of mesh, sort of some mesh 101. And if we have time, I have some slides, and I'd like to talk a little bit about specifically inguinal mesh, again, time permitting. So synthetic mesh, we've certainly come a long way since the days of metal suture and metal mesh, with the exception of going to the Schuldeis Clinic from the lecture the other day. They still use their metal suture there, but we've certainly come a long way. I actually had a patient that I interestingly had metal sutures, interrupted sutures through her abdominal wall, had to cut through these and get rid of them. They fractured just like if you bent a paper clip or a staple enough. So thank goodness we don't use these for routine cases. When it comes to mesh, there's a lot of characteristics that determine what is the right mesh, what is the wrong mesh. Some of the times there's the right answer for all of these things, but there's a lot of characteristics to discuss when we talk about the various aspects of them. We don't have time to go through all of these things thoroughly in 8 to 9 minutes. So I'm going to do my best to breeze through some of this stuff. If you want to have some side conversations afterwards, I'm happy to talk to anybody at the end. First things first is, what is that material made of? And this lecture, again, is focused on permanent materials. Dr. Shao is talking about biological and bioresorbables next. Common materials, polypropylene, polyester, these are the most ubiquitous materials that we use around the world. Each of these has their own pros and cons. Polytetrafluoroethylene, or PTFE, or more commonly EPTFE, or expanded solid laminar sheets like dual mesh. These are also in hybrid configurations where you have the anti-adhesion barrier with a slim piece of EPTFE combined with some polypropylene for various ventral and umbilical hernia repairs. And there's other newer materials, things like PVDF and other hybrids where they take usually a polypropylene backbone and add on some other material with the effort of reducing the inflammatory response to it. So speaking of inflammation, the reason I show you this slide, and this was a rodent model that we did years ago, was to show you it doesn't matter what material you implant. Any material is going to induce some degree of inflammation. It's just that some materials are higher inducers of it. Polyester tends to be a bigger inducer of inflammation versus polypropylene. But if you take a look at the far right there, that actually is UltraPro. UltraPro is a hybrid mesh of polypropylene and monocryl. Because that resorbable component is going to get a heightened inflammatory response, especially in the first several weeks to even the first couple of months. Foreign body reaction is something I always like to look for when I'm looking at histologic examination. And it's a splinter, sort of the classic foreign body. You get these foreign body giant cells, these coalescence of macrophages. Anytime you see foreign body giant cells, that's the body's way of saying, I don't like this substance. I either want to wall it off or extrude it or get rid of the body best I can. And you can see these when you implant mesh materials. EPTFE on the left side, sort of an older traditional three-dimensional polyester on the right side, and every one of those arrows is pointing to a foreign body giant cells. That is, anywhere you see an interface between tissue and mesh, you're seeing these foreign body responses. Fibrosis, every mesh material will also induce some fibrosis. We want fibrosis. We want some collagen deposition within and around the mesh. The problem is the body tends to overdo it. It exaggerates inflammation, exaggerates foreign body response. You get a solid laminar sheet like EPTFE, and there's no ingrowth into the mesh, but you get this thick encapsulation and rind around it. Polyester meshes tend to induce, again, heightened fibrosis. But with regards to solid laminar sheets, especially with EPTFE, you get things like these, where you get significant encapsulation, severe mesh contraction, and these unsavory specimens that we end up having to remove. And that's why we don't use much EPTFE in the body these days for modern hernia repair. I love this paper. This paper is almost 20 years old now by Cobb, Kircher, and Henneford, the argument for lightweight mesh. And this was really a game changer when it came to manufacturing different types and different configurations of mesh. Instead of the traditional heavyweight, microporous, small pore polypropylene mesh, moving on to more macroporous lightweight. And the whole concept of this is that anytime you have a mesh fiber, you create some type of granulomatous scar reaction around it. That's very normal. But when you have thick fibers close together, you develop this bridging fibrosis in between. And that thick bridging fibrosis actually increases mesh contraction. So it's kind of counterintuitive that a lighter weight mesh actually has less mesh contraction compared to a heavyweight mesh. And we saw this in our studies when we looked and compared heavyweight microporous versus a midweight and an ultra lightweight at the bottom there. You can see at the top there with that blue trichrome stain, those really thick bands of collagen. That's that bridging fibrosis. It's almost like mesh cirrhosis. It really is like that. You get this thick fibrotic change, myofibroblast contraction, that mesh will shrink down. But if you can make a smaller mesh fiber, spread it out more, macroporous, you get less of this bridging fibrosis, less mesh contraction. When it comes to mesh weight density, I listed a whole bunch of mesh on the right. This is not a complete comprehensive list, but this is certainly a lot of the meshes that are on the market or have been on the market in the past. There's various definitions of different weight density. These are the ones that we've published and other folks have published. Interestingly, we talk a lot, you see on IHC, I put a piece of mid-weight polypropylene mesh. The reality is that most meshes, especially soft mesh, Prolene soft, Bard soft, these are actually lightweight meshes. They're hanging around 44 to 45 grams per meter square. There aren't too many true mid-weight polypropylene meshes, although there are a couple out there available. And then ultra lightweight mesh, as you can see, is really lightweight. There's not too many on the market right now. The problem is, perhaps, did manufacturers go too far and swung the pendulum too far, making ultra lightweight meshes? And this is some of the complications that we see a result of it. We have central mesh failure. Now, central mesh failure or fracture can happen from a variety of different meshes, different mesh materials, different mesh weights and densities. But sort of some of the lessons that we sort of learned the hard way with these are A, if you have to bridge, and we try to avoid mesh bridging, but the reality is sometimes we have to. If you have to bridge, use a heavier weight mesh. Don't use lightweight structures, especially avoiding ultra lightweight meshes. And then the other kind of lesson learned the hard way is with fixation. I used to be a big fixator, transfascials for my retrorectus and TAR. And the problem was I was probably pulling those too taut. And while most patients did just fine, and some patients, they gained extreme amount of weight post year 1. And with a taut mesh, increasing weight gain, that mesh just ripped and fractured right down the middle. And here's a patient of mine that I had to take for a bowel obstruction in New Year's. Other newer mesh materials, and I say newer in quotes because some of these meshes have been around for over a decade. PVDF, not as found as much here in the United States, but it's been in Europe for over a decade now. One of the interesting things about PVDF and some other newer materials is its resistance to degradation and reduced foreign body response. So that's sort of the trend. I talked to you about that inflammation. What can we do to reduce that inflammation? There always is going to be some degree of inflammation. We want some. It's a double-edged sword. The problem is the body overdoes it. So if we can find a way to reduce that inflammatory response, have a little better mesh integration. Things like Tymesh. This is a polypropylene backbone, but using vapor deposition, they have titanium that is microscopically bound to this. And again, that theme of reducing inflammation, reducing foreign body response, less shrinkage. You can even use these meshes intra-abdominally without the need for an anti-adhesion barrier because of that reduced inflammatory response. Other meshes out there, just to talk about, to round it out, most of the meshes that we use are of a woven or specifically knit structure. Well, there are meshes that aren't made from a woven or knit structure, instead using a microspun technology. This is Surgeon Mesh, this is one of them. Even BioA, I know this is not a bioresorbable talk, but BioA, I believe, is made in a similar fashion where instead of a woven or knit structure, it's this microspun. So just other ways of manufacture, even using similar materials. And the last one here, just to talk about some, some novel ways of doing it. Ovitex is a laminate of a biologic mesh. Again, I'm not talking really about biologics here, but one of their versions has a permanent polypropylene backbone in there. So when the biologic component either resorbs or gets remodeled, you're still left with a permanent structure, a polypropylene mesh construct. I'm going to zip through some of these real quick. I got like a few seconds, just because I think it's important to highlight some specific examples of mesh, especially in the groin, because very different physiology between the abdominal wall and groin hernias. Few studies here. I'm going to summarize these in one slide, and because there is a big difference between an MIS repair and an open repair as far as mesh decision making. Whereas we've been striving to go toward mid or lightweight meshes for the abdomen for groins, actually heavyweight mesh has some really good data to support the use of heavyweight mesh in the groin for lap and robotic repairs, not necessarily for open. I'll get to that in a sec. In fact, if you look at the summary of these studies showing that lightweight mesh increase the risk of hernia recurrence, especially for direct defects. Look at those, the relative risks there on the right side there. But you may say, well, I don't want to induce chronic pain. I don't want to induce foreign body response with my patients. Data does not support that thought. Basically, using a heavyweight mesh did not increase the risk of pain, foreign body sensation, or quality of life. And ultra lightweight mesh should not be used, especially for MIS repairs. So basically, greater consideration for heavyweight mesh for MIS repairs, especially for direct defects. Open repairs, a little bit different. The data doesn't pan out like that, where actually you do have a greater foreign body sensation with a heavyweight mesh. So depending on the type and the size, there may be perhaps leaning toward a lighter weight mesh. And the last thing I'm gonna end with is with my PSA. Sorry to trigger you guys, I might trigger myself with this, is avoidance of mesh plugs and three-dimensional structures here. You know, while still the majority of patients are gonna do just fine with these, there's a small set of patients that are gonna be left with lifelong debilitating chronic pain or other worse reactions to that. So even looking at hernia surge guidelines there, there's a strong recommendation to avoid three-dimensional constructs. These are meshes that span multiple tissue planes, things like mesh plugs, Prolene hernia systems, things like that. You're spoiling multiple planes, you're inducing chronic pain for some of these patients, and it can be pretty morbid to take these out. So a lot to go through. I'm happy to talk if we have time for a Q&A, and I'm looking forward to the next round of talks. Thank you very much.
Thank you, Dr. Ornstein. Next, we have Dr. Jenny Shao from University of Michigan. She's a clinical assistant professor and director of the Abdominal Hernia Center at Michigan. She's a recipient of the Association of Women's Surgery Top 40 Award, as well as a committee member in several organizations, including SAGES, AHS, and Surgical Society of Ergonomics, vice chair for diverse DEI, and inaugural recipient of the ACS Anti-Racism Grant with a focus on DEI. And she's going to talk to us about biologic and bioabsorbable meshes.
Thank you so much for that kind introduction. I didn't even know I had so many titles, but thank you. So I'm here to kind of talk a little bit about this, and I think it's a lot to get through. So just before we get started, I do have some relevant disclosures, but I think maybe the more important ones are the non-financial ones, in which I'm going to just admit that I have actually probably a lot of clinical bias in this space in terms of what kind of mesh that I like to use. And I think, you know, just before I start this talk, I know we're talking about absorbable meshes, but in reality, like most of my practice is permanent synthetic mesh. I also tend to be pretty risk averse, and I'm really interested in patient-driven outcomes and shared decision-making. So that kind of covers a lot of my clinical decision-making. So I'm going to kind of talk about like the need and the rise for absorbable meshes in this space, some of the current evidence guidelines, different types of biologic meshes and their characteristics, and maybe potentially clinically applicable scenarios, and review some key takeaways. So I think we've really seen the rise of non-synthetic hernia mesh even within the last 5 to 10 years, right? And I think we all know that there's many patient and hernia factors that may influence these decisions. We're fixing hernias in more comorbid patients with very large hernias, and I think we're starting to see patients with a BMI that tend to be higher and higher. And so in these settings where patient factors are not optimal, sometimes we can't always do a permanent synthetic mesh. Also, I think we're seeing mesh perception and medical legal concerns that have risen, especially here in this particular country, right? So we have a lot of surgeon fears and patient fears about mesh. How often do you have a patient who enters your office that says, well, what about that hernia mesh? It's literally every single hernia patient I see, and I'm sure all of you pretty much feel similarly. So this is kind of an interesting slide. This is based out of the Michigan Surgical Quality Collaborative data, where we have data across about 70 aggregate hospitals in the state of Michigan. So this is just absorbable mesh usage in clean cases in the state of Michigan. You can see the hospitals labeled by number. So there are certain hospitals in the state of Michigan that are using 100% absorbable mesh in clean cases, and then there's some that are using 0. So I just show this to say that there's a lot of variability out there, and I think not all of it is evidence-driven and probably driven by a lot of the factors that I'd previously mentioned. So, I mean, not surprisingly, we all know that hernia mesh does not have a great rep, right? Like we have a lot of studies that talk about this. So Dr. Tofai, one of the presenters later today, she and my previous fellow, Desmond Young, they did this amazing study about social media and its influence and perceptions about mesh. And when you look at word clouds and obviously what our patients see, you see sorry, pain, problems, regret, damage, suffering. So all of these are very negative connotations about what mesh is. And I think that's driven a lot of this market for absorbable meshes. And so, of course, there's downsides to synthetic mesh, but there's also downsides to absorbable mesh. So, of course, chronic inflammatory response, potential for infection, medical legal concerns. But on the flip side, you have increased recurrence rates, increased costs, and higher likelihood of needing additional hernia surgery. And so I think a lot of the current decision making sometimes is really, as I said before, driven by surgeon and patient biases. And so how can we kind of sort through that and figure out who is truly a good patient for absorbable mesh versus permanent synthetic mesh? So I'm just going to review some randomized controlled trial data. So this is a really great systematic analysis or meta-analysis and review of the only 4 randomized controlled trials that currently exist right now comparing synthetic versus biologic mesh. So total in these 4 trials included just over 750 patients. You can see between the biologic mesh and synthetic mesh, the groups are pretty evenly split. 3 of the studies looked at Stratus and 1 used Surgisys Gold. So what you will notice that's really kind of interesting in these studies is the technique and the mesh location is very variable, and then the wound class is also very variable. So even though these are randomized controlled trials, there's a lot of heterogeneity in the types of studies, in the types of location of where you're putting the mesh and the technique of the mesh, of how you're doing the actual hernia repair itself. And then, of course, when you look at wound class, it's no surprise that, for more contaminated cases, you potentially have higher risks of recurrence. But also, I think a lot of these were contaminated, potentially bridging repairs in which you would expect that recurrence. And so I'm going to start to sound like, a medical ad commercial here. So there's a lot of limitations to this, right? So heterogeneous patients, increased complexity, recurrence, varying operative techniques. So some of these are bridging IPOM repairs, contaminated cases. Some of these include peristomals. And most likely, a lot of these studies are really underpowered for outcomes. And there's probably a high fragility index if you've seen Dr. Todd Hunniford speak about some of this to some of these studies. So I think what I'm truly trying to say is that I don't think there's a lot of really great data out there for synthetic versus biologic mesh. So on the flip side to this, this is a study coming out of Carolinas Medical Center. It's actually ahead of Brent, but Dr. Augenstein kindly gave me permission to sort of share this. So this is a retrospective match cohort study, about 500 patients and a 2-to-1 match for patient characteristics and hernia characteristics. And you can see there's about 350 patients in the synthetic mesh group, 173 patients in the biologic mesh group. If you look at their intraoperative details, what I think is really different about this study versus some of the other randomized controlled trials is really truly the rate of fascial defect closure. So these are actual definitive hernia repairs that are being done in clean contaminated cases that are achieving fascial defect closure and mostly extraperitoneal mesh placement. So these patients are actually undergoing like a true definitive hernia repair with the biologic or synthetic mesh. And when you look at their post-operative outcomes, of course, the total charges are higher for the biologic mesh as would be expected based on the mesh implant, and the 30-day readmission rates are higher. But if you look at the recurrence rate at the follow-up of 2 to almost 3 years, it's actually fairly equivalent. So I do think that there probably is a lot more evidence that we can explore out there, and we probably don't have very good data for some of this yet. So this paper is coming out, it's ahead of print, so be sure to read it when it's available. And so as we transition to the talk about the indications for the usage of absorbable mesh, I think for the bulk majority of ventral hernia repairs, you can use a permanent synthetic mesh, right? But I think there's that 5 to 10% where really a synthetic mesh is not the right type of mesh for that patient. Are you contaminated? Are you high risk? Is it emergent? Other reasons why it should be avoided. And I will say that there's a disclaimer that really there's no mesh that's FDA approved and affected or clinically contaminated setting. So if you do use it, it's kind of off-label use for any type of mesh. So Dr. Karkling's here in the audience today, but he and a group of people in the biomesh group wrote this really great review article looking at the evidence for use of biologic or biosynthetic meshes in abdominal wall reconstruction. This paper's several years old, but I do think they do a great job of going through all of several key questions. And I'm only going to present a couple of them today because the paper in itself is great. So please go and read it. But one of the first key questions is, are biologic and biosynthetic meshes more resistant to infection than synthetics? And it should come as a surprise to anybody that it's no. So, right? So biologic, biosynthetic meshes can still get infected and infections can still occur in the contaminated setting. But what they did find in the evidence is that actually you have fewer mesh explantation. So even if you do have an infection, you may not necessarily have to reoperate and take that mesh out. But really, cumulative data does not support that biologic or biosynthetic meshes is better than synthetic meshes in the contaminated field. It doesn't say it's better or worse, and the level of evidence is really moderate for this. So for the next key question that I thought was kind of interesting is for bridging biologic repairs. So I think this is meant for bridging ventral hernia repairs in a permanent, like definitive hernia setting. And so it should be avoided when bridging is needed, right? Because once that mesh dissolves, it's going to completely go away. So in settings where you're completely clean elective case and you have to do a bridging repair, you should probably use a permanent synthetic mesh. So for complex abdominal wall hernia repair in the emergent setting, when you have incarcerated bowels, so this is an indication for potentially biologic or biosynthetic meshes in contaminated or dirty fields where when fascial defect closure is possible. So the level of evidence on this is pretty low because there's very few studies that were included in this. But I think it's kind of interesting because all of us have those emergent cases where do we put mesh, do we not place mesh? And so sometimes we just opt for a primary repair. But I think in the setting where you can get the defect closed, potentially you can use a biologic or biosynthetic mesh in this particular field. And then so for intercutaneous fistulas, if you can use a biologic mesh to do a single stage repair without bridging with acceptable outcomes, potentially this could be a space that you can do it. But of course, the level of evidence, again, is very low, and there are very few studies that were included in this. And so now, like you're in the operating room, but how do you choose the right mesh? So I think in an elective non-contaminated case, you should probably just place permanent synthetic mesh, right? Like if your patient has mesh concerns, I would really just review the evidence with them and say, I think generally it's very safe. I like to compare a lot to knee replacements. A lot of my patients have already had knee replacements. And I just tell them, you know, it's a permanent synthetic material that's going to be in your body forever, just like your knee replacement. The chances you can actually probably get an infection from it is really low once you get out past the surgery, but nobody would get an absorbable knee, right? So why would you get an absorbable mesh? It just doesn't make any sense to me. And I think when you reframe that conversation, people really understand that, right? They're like, oh yeah, that's true. Like I do have a knee replacement that's going to be there forever. I don't really worry about that so much. So why am I worried about the mesh? So in elective high-risk patients, I really, I don't want to say offer them the option of biologic or absorbable mesh, but I do think there's a little bit more nuance to that shared decision-making algorithm. And I really have a straightforward conversation about them, about the risks of infection versus the risk of recurrence. So for instance, one patient that I recently operated on had a heart liver transplant. She still needs a kidney transplant, has had a history of systemic fungemia. So she was somebody where we both decided biologic mesh is probably the best choice for you because you're super young, you're probably going to need multiple operations and the risk of infection is just way too high. And so I think you really just have to approach each patient with a nuanced decision. And I don't think that one decision suits all. And then so for the emergent elective case with contamination, I think if you have very controlled contamination, potentially you can think about placing a permanent synthetic mesh. I think we have studies where we can do concurrent cholecystectomies and ventral hernia repairs, and that's generally shown to be pretty safe. But I think if you're super uncontrolled, if you're a dirty contaminated case, just do a primary suture repair if you can and get out of there. Because usually in that case, the hernia is not the first priority, right? It's usually an aseptic patient who's also very sick. Your goal is to save their life. Your goal isn't to fix their hernia. So I think it just depends on the clinical scenario and the situation and how to make that right decision. And so once you've decided to use an absorbable mesh, yes, I can move on. Okay, so of course there's many different options. Definitely very hard to choose. And so I was just going to say that I think the mesh choice just depends on the clinical situation. I'll just give you a few examples. So I tend to use Stratus in, hernia repair in high-risk select patients, paraesophageal hernia repairs. I sometimes use it to bridge in an open abdomen, especially when they're not ready for a definitive hernia repair, fascial closure. I like to use BioA for paraesophageal hernia repairs. I like to use FibroMesh for patching posterior layers. I also occasionally use Phasix or plus or minus ST for preperitoneal hernia repairs, and especially in women who plan to have kids in the future, or prophylactic mesh onlays for potential prevention of dehiscence. And of course, these are my personal opinion and kind of what I do. And so you may not necessarily make the same decisions. So the key takeaways really, I do think they have a role in hernia repair. It's going to be up to shared decision making, and it's going to be up to us to make smart decisions and educate our patients about what's appropriate and what's not. Thank you so much. Looking forward to your questions.
Thank you, Dr. Chow. Let me invite some of the people standing in the back. There are some seats up front. Now's a great time to come take one. And our next speaker is going to be Dr. Artem Shmelev from Stony Brook. He's a clinical assistant professor of surgery and co-director of their hernia center, and he will be discussing the mesh or the meshes, mesh complication, or the mesh or the mesher, sorry, need my reading glasses, mesh complications in litigation.
Thank you very much for the introduction and for the invitation. It is an honor. We'll talk today about the past and active lawsuits. How do you switch the slides here?
Here's the.
Oh, wonderful. Thank you. So we'll talk today about past and active lawsuits against hernia meshes. I have no mesh-related disclosures. Francis Osher introduced polypropylene mesh for hernia repair 67 years ago. 30 years later, gynecologists started to use it for pelvic organ prolapse and incontinence. It is infamous transvaginal mesh that caused more than 100,000 severe complications and triggered multiple lawsuits. Public interest in transvaginal mesh peaked in 2011 when FDA reclassified it as a high-risk device. 8 years later, transvaginal mesh was banned by FDA, but negative connotations surrounding the buzzword mesh remains. The first and probably most well-known class 1 recall of hernia mesh happened in 2005 when Bard withdrew from the market the Kugel patches. The hard memory ring was breaking and causing injuries to surrounding viscera. Same interest to specifically hernia mesh peaked in 2016 when first litigations were filed against Physiomesh, Secure, and Pariedex. This public interest continues to slowly grow. Most recent developments surrounding mesh litigations are several global settlements reached in the last 2 years, as well as pending negotiations in Bard multi-district litigation and first bellwether trials in Covidien MDL. As of now, there are still thousands of pending individual hernia mesh lawsuits combined into 4 MDLs. Class actions and multi-district litigations are 2 ways to combine similar cases into one trial. In brief, MDL maintains more individual case autonomy, as injuries are not fully identical. Cases in MDL are resolved either individually or through a global settlement. Over the last decades, MDLs became an important tool for managing complex litigations. Almost a half of all civil cases in the federal court system are consolidated into MDLs. There are mere 3% of federal judges who are overseeing these cases. Overburdened MDL judges may make inaccurate decisions and neglect nuances of individual cases. Having said that, MDL's popularity continues to grow as the gains in overall time and cost effectiveness are significant. MDL attorneys work on contingency fee basis and receive at least a quarter of the total settlement. The typical life cycle of an MDL involves bellwether trials. These representative trials are providing insights into potential jury outcomes in a large group of similar cases. By the number of cases, the largest active individual hernia mesh MDL takes the 3rd place after earplugs and talcum powder. Amongst all medical devices, all hernia mesh MDLs combined have around 33,000 cases, which is a third of transvaginal mesh cases. By the settlement size, the largest so far hernia mesh lawsuit is a fraction of the settlements in prosthetic joints or earplugs. The largest hernia mesh MDL against Bard is still pending the settlement. So what are the allegations in the 4 hernia mesh MDLs? First settled MDL is against Atrium Secure. This polypropylene mesh has omega-3 coating. Secure was linked to issues with sterilization and higher infection rate. Secure was linked, MDL with Secure was settled in 2021, but there are still some pending cases. Ethicon Physiomesh is a low-weight polypropylene mesh with monocrylene PDS coating on both sides. It demonstrated doubled recurrence rate in European databases and was removed from the market in 2012. High recurrence is likely caused by poor integration on the parietal side. Global settlement was reached in 2021. The largest hernia mesh MDL is against polypropylene meshes by CR Bard. Allegations are quite wide and include chronic pain, recurrences, adhesions from failed anti-adhesive barrier, fistulization, bowel obstruction, infections, and so forth. Settlement negotiations are underway, and there are still 23,000 cases pending. And finally, Covidien MDL against polyester meshes is still in its investigational phase. Allegations are essentially the same as with BARD, and bellwether trials are scheduled for next year. Let's look into details of the first BARD bellwether trial. The plaintiff underwent laparoscopic IPUM with ventrolite ST and diastasis plication. A year later, there was a clinical suspicion for recurrence, and he was taken for redo IPUM. The same surgeon found that repair remained intact, but the diastasis plication broke. Old mesh was removed and a new IPUM mesh was placed, same ventrolite ST. And not unexpectedly, there were some mental adhesions which required about an hour of adhesiolysis. 3 months later, he again noticed similar symptoms. He didn't seek medical care for 3 years, and then in 2019, he presented for open-only repair. The plaintiff claimed pain, anxiety, potential threat to his health, and adhesions. The court approved the claim about adhesions, but dismissed claims about suspected hernia recurrence in 2016 and the need for further surgeries. FDA recall database returns 130 results for mesh search term and 170 for matrix. Of those, less than 20% are actually recalls for hernia mesh. Here's a summary of hernia mesh recalls. Only 2 Class 1 recalls were issued, which required immediate market withdrawal. These recalls are for Kugel patch and for Zen matrix for contamination. Most of 24 Class 2 recalls are labeling errors, either wrong size or laterality. And there are also issues with packaging and sterility. But more meaningful for us recalls are related to mechanical mesh failure, such as lightweight polyester mesh, Paraitix failure with modified sugar baker, central mesh failure of large size, medium weight polyester, Versitex with tar. Mechanical failure is also a known issue with lightweight monofilament polyester meshes and ultra lightweight and low weight polypropylene meshes with incomplete anterior fascia closure. And given concerns about mechanical failure, some groups suggest use of midweight polypropylene for large ventral hernias. We discussed higher recurrences in lap IPUMs with physio mesh, likely related to poor integration, and sterility concerns with Secure. Proceed mesh has issues with delamination of its anti-adhesive barrier made of oxidized cellulose. But as of now, you see that most recalls are related mostly to mislabeling and concerns about sterility. If we make a whole pool of potential mesh-related issues mentioned in lawsuits and recalls, many of them we see in our clinical practice. We can define 3 main factors: mesh properties, surgical technique and decision-making, and patient's characteristics. Many of the complications we see are, of course, multifactorial. Let's start with unequivocal mesh issues. Amongst them are sterility concerns, faulty design, insufficient tensile strength. As we know, material and mesh density do affect the degree of chronic inflammation and mesh contraction. Purely surgeon's fault is a selection of not large enough implant and lightweight meshes for repairs without defect closure, such as large inguinals and breached ventrals. It is in surgeon's hands to avoid avoidable enterotomies and to isolate uncoated synthetic and viscera. It is in our hands to perform clean anatomic dissection and avoid injuries to neurovascular structures. Of course, patient factors play a major role in wound complications and degree of adhesive process. We also saw pristine IPUMs a couple of years out and tops covered with adhesions. Since complications of hernia repairs in general and complications related to mesh largely overlap, the ways to mitigate them are similar. From mesh selection standpoint, consider heavy implants for bridging repairs and large inguinal defects, as Dr. Schoenstein alluded to, and place your coated mesh intraperitoneally only, and definitely avoid complex 3-dimensional meshes in the groin. Always use sufficient overlap. Dr. Lima later will talk about what is enough, and strive for clean dissection in case. Rehabilitate your patients. Control modifiable risk factors. Choose the mesh class depending on patient's comorbidities and contamination. Don't burn the bridges. And finally, have a good, candid discussion with your patient and set realistic expectations. We all see patients with genuine concerns about the mesh. Dr. Tofai will show us the patient's perspective. I believe it's critical to explain why you need to reinforce the repair. You can use simple analogies from daily life. I encourage my patients to look up the AHS mesh advisory statement. FDA also has a mesh statement. They specifically mention that complications can occur regardless of mesh utilization. And if you feel that in your hands, non-mesh repair will likely fail, consider referring for a second opinion, or you may consider slowly absorbable products. That's all I have. Thank you very much.
Thank you, Dr. Schmeller. Next, we have Dr. Shirin Tofai. She's from Beverly Hills Hernia Center. She's a world-renowned surgeon and mentor and educator. and will speak to us about putting ourselves in other shoes.
Thank you very much. I have no financial disclosures, but as many of you know, I moderate and own the herniatalk.com website, which is a free patient discussion forum from which I gain a lot of my experience. I'm also involved in many of the social media patient advocacy groups, which also I'll kind of show you what I learned from that. So welcome to my practice. Let's go over a few patients that are relevant to this mesh talk. So 35-year-old female, umbilical hernia. She doesn't want mesh. That's patient number 1. Patient number 2, and these are actual true people. Surgeon in Los Angeles, he knows he has a hernia. It's actually symptomatic. He just operates and sticks it back in. At the end of each case, he has multiple incarceration episodes, but he's delaying his surgery, as most surgeons may. Patient number 3, I flew in from here, Chicago, all the way to Los Angeles because he felt he's sick and wants his wires and mesh removed. Patient number 4 flew in from Louisiana. He wanted a non-mesh inguinal hernia repair, and he knows that I do offer that. And patient number 5 flew in from Ohio. He had a recurrence, and now that he's had a recurrence, he doesn't want mesh anymore. And lastly, patient number 6, very complicated surgical history, open abdomen, skin grafting, really prefers not to have mesh, or maybe use an absorbable mesh like Dr. Shah was talking about. So what is the underlying message, and why are people coming to me with these requests, and what I need to understand the patient's perspective to better treat them? And really the underlying is it's fear. All these patients are knowledgeable, they're reading, but what they're reading is giving them fear. So my direct question to them when they come to me is, I don't disparage them or call them stupid. I say, okay, why don't you want the mesh? Like, what's the underlying reason? Well, guess what? That first patient, her mom actually died from mesh. She had a mesh complication with a fistula and eventually died from sepsis. And we've all experienced that. It's a real problem where you can have complications with mesh. Multiple studies have shown this. We know that we can get complications and even death with mesh. This is a great long-term study which shows that of the ventral hernias performed, if you follow them out far enough, 11.9% died during the follow-up period. 0.1% of those deaths were mesh-related complications, specifically in laparoscopic repair. One was due to bleeding and tearing of a vessel by attack. Another one was from bowel perforation due to mesh migration into the bowel. And the third was a bowel obstruction. These are real, you can die potentially. But notice this, in the patients that had, let's say, a non-mesh repair, 0 fistulas. That's what the patient's going to hone in on, right? And therefore, I don't want mesh. So patient number 2, this is a true story. This friend of mine, he was worried about chronic pain. I don't know why he didn't just come to see me, but regardless, he was worried about chronic pain if he had his hernia repaired. So his solution was, there's something called watchful waiting. I'm just going to watchfully wait. And he knew that there's chronic pain available with mesh or non-mesh, but in general, any hernia repair will give you chronic pain. So he felt his incarceration episodes were not worth undergoing surgery. And what he didn't understand was the watchful waiting trial was for minimally symptomatic men, and having multiple incarcerations did not put you into the watchful waiting criteria. And actually people that were randomized to treatment or not treatment, though not statistically significant, tended to veer towards having more pain than those that actually got repaired. So this is actually his CT scan during one of his ER visits where he couldn't personally reduce it, and one of his residents had to reduce it for him. Anyone know what this diagnosis is? What is it? It's French. What is it? Letray? No. This is called réduction en masse. It's reduction en masse. So this is what happens when you have chronic hernias that keep us incarcerated. You get inflammation. and now the neck of your hernia sac is strictured down, and this is his hernia sac. I actually outline it for you, but it's intra-abdominal. So you still have his bowel obstruction, but it's intra-abdominal. And of course, a surgeon would get this problem. But he for sure not only got mesh, but he also got an emergency surgery, which may increase your risk of chronic pain. So everything he was doing was the wrong thing to reduce chronic pain. That's my point. But he's a patient, right? It's a patient's perspective, and he's a surgeon as a patient. Okay, next patient. Yeah, this guy, he read on Facebook that mesh can make you sick, and he felt sick. So of course he may have mesh. He never had mesh in him, but that's beyond the point. We know there's something called Asia, also known as Schoenfeld syndrome, which is an autoimmune or inflammatory syndrome induced by adjuvants. We term the mesh implant illness as a subset of Asia, which is when you actually have these reactions to your mesh implant. And if any of you listened to my great medical students talk yesterday, she showed the survey we had of 815 patients and their implant illnesses. And these are the symptoms they come up with. 71% of them report their health was worse after their implant surgery. And these are common. Look at these, 20% or more had these symptoms: chronic fatigue, arthralgia, sleep disturbance, brain fog, impaired concentration, rashes, flushing, itching, hair loss. So these are real. We don't know what the incidence is, but people talk about this. And some of the comments from our survey are listed, but the one that hit me the hardest was when someone wrote in the survey, surgeons need to present options and educate their patients. And that's what we need to do. Social media groups, if you go through them, a lot of them are negative. We published a paper on what happens with social media, and there's a large volume of discussion about hernia mesh, but specifically, if you look at red, those are the negative ones. It's almost all negative. And a lot of the discussion is about how bad mesh is. And if you go to Twitter, actually look at the top contributors besides me on Twitter, and they're all law firms that are promoting these negative posts. So we already went through all the different funding by lawyers to promote the mesh litigation. And this poor patient didn't even have mesh or wires, but he was so afraid that he was sick. So I took it out. Okay, this gentleman, he waited because he didn't want chronic pain. So he waited, he knew he didn't have pain. So he's like watchful waiting until it got to be a big scrotal hernia. And I had to explain to him that even with non-mesh repairs, you can get chronic pain. And why is that? The reason is because you can tear through the mesh, through the sutures. You can pull on the sutures. That causes chronic pain. Having a recurrence from a tissue repair implies you're tearing, and that's very painful. So here is a post on Facebook, and it says, my surgeon did no mesh because that's what I wanted. And of course, that was the wrong decision. The patient admitted to it. He said, I should have used mesh because now I have chronic pain, which if I had used mesh would have been a better repair and less chronic pain. So these are discussions that are real. And then there's this patient, he didn't want mesh because he had a meshoma and he had a mesh plug put in. So now for his recurrence, he doesn't want to fall into that trap again. And this is just my idea of listening to the patient. Why are they complaining and don't want the mesh, and listen to them? And you can tell them, yeah, hernia recurrence is better with mesh. It's lower and it's a better repair. But they'll tell you, okay, what's the difference? 5%? I'll take that 5% difference. Statistically significant, but clinically to them, not relevant. And then lastly, this patient, he just, I said, listen, man, this 22 centimeter defect is not going to close on its own. But he read a lot about absorbable meshes. And I just want to urge, there's a surge in offering absorbable meshes. It definitely has a role, but there's been a lot of negative press about permanent meshes, and perhaps industry is promoting their product more than they should. There's definitely no situation where on an elective basis, an absorbable mesh performs better than permanent mesh, and certainly not in these complex hernias. Same with sutures, by the way. So the patients are influenced by promotions, and there's lots of discussion. And here's another quote about dissolving meshes and the problems they're having with dissolving meshes. So that's the end of my talk. My patient did very well with permanent mesh. He got a lot of it. very happy that his belly button, which is the far, 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 far right, is now towards the middle. So thank you very much. I just want to share the patient's concerns. These are some quotes. They're worried about why we're putting so much mesh in, and they don't want to reject the mesh. But believe your patients. It's their cry for help. They look to you to kind of calm themselves down. Don't be tainted by the very few but vocal anti-meshers. Don't dispel your patient's complaints. You don't know what you don't know. And do consider learning and offering a wider range of hernia repair options. And if you can't, or if it's too complicated, refer them to specialists that will take care of those patients. And if you'd like to either peruse Hernia Talk to see what patients are saying or contribute as a surgeon, I would invite you to go on the website. Thank you very much.
All right, our final speaker with the only mildly suggestive talk title of Does Mesh Size Matter? A mesh to defect overlap to evaluate ventral hernia recurrence using the ACHQC database. We have Dr. Diego Lima from Montefiore Medical Center, where he is currently a general surgery resident focusing his research on hernias.
Thank you. Thank you so much for the opportunity. Thank the organization. I'm a PGY3 at Montefiore, and we're going to talk today about mesh overlap, mesh defect overlap using the ACHQC database. I have nothing to disclosure. So we know that the long-term success is directly related to of the ventral hernia repair to minimizing the risk of recurrence. And we've been taught and also that using the mesh and with a good mesh overlap will decrease this risk of recurrence. We see the guidelines and also systematic reviews and retrospective studies trying to elucidate what's the better overlap for mesh to defect. And we have the guidelines from the European Hernia Society and the American Hernia Society saying basically like that for hernias smaller than 1 centimeter, 2 centimeter overlap for open repair, between 1 and 4 centimeter hernias, higher than 3 centimeter overlap, and for all laparoscopic or hernias bigger than 4 centimeters, an overlap of at least 5 centimeters. And this comes initially from the study from Professor LeBlanc. I mean, he had 95 papers. I don't know if he was in a sabbatical or something. He had a lot of time to work on this by himself. But he found that for the open procedure, mesh overlap had no correlation with recurrence. For the laparoscopic procedure, the risk of recurrence was decreased with the increasing area of the mesh overlap. Another study from the team, and Jenny was one of the authors, they evaluated 4,000 patients, but mainly looking at operative factors associated to have this sufficient overlap, not really looking at the recurrence. So the objective of this study is to assess the predictive value of this mesh overlap for recurrence after 1 year in patients that underwent ventral hernia repair using the ACHQC database. So inclusion criteria: adult patients that underwent ventral hernia repair, primary or incisional, robotic, laparoscopic, open, with 30 days and 1 year follow-up, clean, wound levels clean, just one mesh, permanent synthetic, in all elective cases. So we started with 20,000 patients. We ended up with 5,000 patients in our study. We had 3 different groups: small hernias, hernia with more than 4, medium between 4 and 10, large, larger than 10 centimeters. And we used the mesh overlap, the mesh width minus the hernia width divided by 2, also looking at the length. And then we ended up with 3 groups. For small hernias, 1,500, medium hernias, 1,900, and large hernias, 1,600. When we look at the demographics, and I'm going to break these in 3 different analyses for these 3 hernia sizes real quick, but we see here mainly that the BMI for the patients with small hernias and with an overlap higher than 5 centimeters were higher compared to the other ones. And they were there was no difference like between smokers, And dividing this, let's break down for the small hernias, smaller than 4 centimeters, looking at the intraoperative characteristics. We see here that the higher overlap with recurrent hernias, it makes sense. You have a recurrent hernia, you are aiming for a larger overlap. And you see also that more laparoscopic and robotic repairs also with this overlap. When we look at the perioperative outcomes, we see sublay as the most common, intraperitoneal, 60% for this small hernia with overlap higher than 5 centimeters. And postoperative outcomes, we see basically SSO is higher for these patients, 10% versus 6% for patients with overlap higher than 5 centimeters. Seroma, 80% versus 4 and 1% in the other two groups, also statistically significant. And one thing that we found, and it was kind of, it was difficult for me to process, I tried to understand this, is that the patients that had a higher overlap, they had a higher recurrence after 1 year. And I was trying to understand this, and it was even difficult to sleep. But I don't know, maybe more complex cases. I don't know if surgeons were causing some damage around the area, trying to get this overlap. So we're still trying to digest and figure out why these patients had a higher recurrence rate after 1 year, even though they had a larger overlap. And when we do the logistic regression, we see this. We see a risk of odds ratio of 1.6 and is statistically significant for overlap higher than 6 versus less than 3 centimeters. Looking at the medium size hernias, again, we see the incisional hernias, 96% with an overlap higher than 5, and the recurrent hernias also, they have a bigger overlap compared to the other groups. And then we see here basically more open surgeries compared to lap and robotic. And when we look at the intraoperative results, again, sublay is the preferred area to put the mesh with heteromuscular higher than preperitoneal. In this group with a larger mesh overlap. And we see obviously myofascial release, TAR, higher also in this group, 64% compared to the other groups. And here now it makes more sense. We didn't find any difference in postoperative outcomes, wound morbidity, readmission, reoperation, anything like that. Also, when we look at the 1 year recurrence, now we see, okay, it makes sense. It's lower than the less than 3 or between 3 and 5 centimeters groups, 11% versus 14%. And also when we do the logistic regression, we find this 0.5 with the statistically significant with the confidence interval 0.4 to 0.8 here. And when we look at the SSO, also for these, we found there is no difference when for the overlaps. We find like BMI or smoker as with increased odds of having SSO at 30 days, it's 30 days. And for large hernias, more than 10 centimeters, intraoperative outcomes. Again, more incisional hernias, more recurrent hernias also in the group with a larger overlap. And 95% of these surgeries were open. Intraoperative outcomes, again, sublay, most common, TAR also 94% in these patients with a larger overlap of 5 centimeters. Postoperative outcomes, no difference, readmission, reoperation, SSI, SSO, seroma, hematoma between the groups. And when we look at again, at the 1 year recurrence, it's 3 to 5 centimeter overlap or higher than 5. Good results compared to an overlap smaller than 3 centimeters. And we can see here in the logistic regression as well that a larger overlap will there's decreased likelihood of developing, having a recurrence at 1 year. For SSI, no difference between the overlaps, no increased likelihood of developing SSI. For SSO, the same compared to these 3 overlaps. There's not increased risk of developing SSO. And also for readmission, the same thing for the overlap. So our study has limitations. This is retrospective data. We have surgeons that are dedicated to abdominal wall repairs in this database. This is a voluntary input of data, and we have obviously we look at patients with 1 year follow-up, but we have attrition bias if you want to look for a longer follow-up. In conclusion, for small hernias, this large overlap did not decrease the risk of recurrence, but we increased the risk of SSO. And for medium and large hernias, a large mesh overlap was beneficial to prevent 1 year recurrence without increasing the risk for postoperative complications. So thank you so much for your attention, and I'll take any questions.
Well, I think all of our presenters gave us some thought-provoking things. We have just under 5 minutes for questions, if anyone has a burning one. I'm going to start with Dr. Tofai. How many of your patients come in asking if there's a way to tell ahead of time if a synthetic mesh will make them sick, and what do you tell them?
How many come in asking? I would say a good proportion. And I tell them, in our study, you have to be female, thin, young, and the majority of them, almost 80%, have some type of autoimmune disorder. So if you're not in that category, I'll say, listen, I can't guarantee you anything. And we don't know what the percentages are, but if you're a male, average body habitus, whatever, you don't fall into that kind of criterion that we tend to see. And so I'm not usually worried about a risk for mesh implant illness.
I think I'm gonna fully admit that I'm gonna have a cardinal sin because it's not a question. I just want to make an important comment about the last concept of research that we were doing. When we look at ACHQC data, we're taking data from people who made a clinical decision in the moment because they thought it was best for the patient. And a lot of times that is related to both patient characteristics and hernia characteristics. So what that means is if they get in there and there's diastasis or something like that, that they're not necessarily capturing, they're going to say, I think I might want a bigger piece of mesh underlay, or I'm going to decide to put this underneath instead of on top, because most of the people in ACHQC actually have the skills to do all those different techniques. So it's not like, oh, we have a group of people doing it this way and a group of people that. So the problem is that we keep talking over and over again about this is what the data that we have, and we're asking whether it is increasing the risk of something happening. So 2 things. 1, these are all retrospective reviews. We never calculate risk, period. That's a statistical fact. We don't calculate risk, we calculate odds. And why that's important is because we don't have control of the decision-making. And what we're doing is we're saying it's just an association. So I find that data actually fascinating. You have a ton of fascinating data there, but I just want to really caution everyone from saying, okay, we now can make a decision that says the overlap or this is causing either SSOs or causing increase. And I think that's part of why you see higher recurrence rates with more overlap, because what's happening is people are saying, well, I'm more worried about a recurrence, so I'm more likely to increase the size of the mesh. And then, yeah, they did. They have more recurrences. So they're making that decision because of that. And the reality is that we'll never know because we just don't have that data. So I don't know if anyone wants to comment about that, but I've seen that kind of over and over again. And I just thought that was a really good example of, like, I think something we have to be very careful about.
No, I think you're right in that, the QC data is biased, right? I mean, it's not a randomized study. There is always going to be an element of surgeon selection and choice and bias in it. And that's why it's important to keep that in mind in those studies.
Yeah. And just to clarify real quick, you're absolutely right. There's bias, and everybody puts up the slide at the end that says, hey, it's retrospective. Hey, it's this, but it's a lot like we do with our, we say, oh, we consult for X, Y, and Z, but now we're going to give this talk, but it's not really related, right? It's the same way. those things, we have to know whether or not the question that we're asking is directly related or isn't directly related. In that case, I'm worried that it is directly related, and randomization isn't going to solve necessarily the problem that I'm bringing up, because that's a decision-making problem about other things related to it. I just wanted to bring that. Did you have another comment?
Oh, yeah, sure. No, I mean, obviously, observational retrospective studies, they don't give you causation. They just like you said, increase the odds of, the odds ratio, like we show with the logistic regression. It was just like maybe the expression that uses increasing risk is not exactly right.
Yeah.
But the data is the data that we have. That's data we have to work with. And we obviously can go for clinical trials and systematic reviews, meta-analysis. And even when you look at systematic reviews and meta-analysis, they also have a lot of problems. But like it's like they say, in God we trust, all the others must bring data, and we have to work with the data that we have.
Yeah, you're absolutely right. We have to work with the data we have. We just have to be careful to ask the questions that can be answered with the data that we have.
Sure.
That's
All right. Unfortunately, we are out of time, but you can definitely come up to our speakers in between. Thank you all for attending this session.